Okay, so now that we've talked about our immediate care and using cryotherapy for that, we're going to move it into post-immediate care. And this is probably where the most confusion around using ice exists. So let's talk about some examples of cryotherapy. We have our ice and cold packs that we already talked about in our immediate care. We have our Kinetics that we're going to discuss, which is using cold to facilitate exercise, which seems kind of counterintuitive with some of the physiological effects that we've already discussed. Cryo stretch, again, using cold to help facilitate relaxation of a muscle. It's also something that seems a little counterintuitive. There's cold water baths or whirlpools or immersion, cold compression devices. So we're going to talk about intermittent compression, ice massage, where we use essentially massage a giant ice cube across someone's an area of their body. Running cool water over a burn is a form of cryotherapy. Medical induced hypothermia, so sometimes used in spinal cord injuries to again decrease the metabolic needs of the spinal cord until surgery can happen to help increase the likelihood that the cord might regenerate or recover or further damage won't happen. Also, we medically induce hypothermia when someone goes through heart bypass surgery and they lower the body temperature so that the body can withstand that time away from oxygen. Cryosurgery, so something as simple as freezing off a wart, right? Up to more extensive use of cold therapy for surgical techniques. So we've already talked about using cryotherapy in immediate care. So again, talking about trying to keep metabolism low, decrease secondary cell death. We usually talk about applying for about 30 minutes. Our post-immediate care, we're talking about cooling tissues during and in combination with rehabilitation or as an adjunct to other therapy or exercises or as a pain reliever. Those are probably the main reasons of using cryotherapy post-immediate care that we're going to focus on. Obviously also a surgical adjunct, as we discussed with the medical-induced hypothermia and the cryosurgery as well. There's also miscellaneous reasons for using cryotherapy. There's research that putting ice on a cold sore will decrease the outbreak of the herpes virus. Using it for pain relief before injections. It's even more beneficial than heat for menstrual cramps, which again, most people tend to go towards heat because it feels more comfortable and you feel nice and relaxed because of the sedation factor of heat. But actually in research it shows that ice is actually better for those things. So post-immediate care, our goal switches from all of that decreasing the cellular activity and preventing secondary cell death to now an adjunct to facilitate rehabilitation. In that we want to decrease pain and or muscle spasms. The idea being that if we decrease the pain or decrease the muscle spasms, they're more likely to be able to participate in rehabilitation and do things like that. So yeah, our goal becomes to try to allow earlier mobilization, especially if that's limited by pain from the initial injury. And so cold compression devices and intermittent compression that we're going to talk about, as well as cryokinetics, are two ideas that we utilize for that post-immediate care. However, caution with that. So when we're talking about facilitating exercise by essentially reducing pain, we got to think about the fact that too vigorous of an activity, especially when already cold, which is going to decrease the proprioception and decrease the strength, the rapid onset of strength, could result in problems. And so we are going to monitor those processes really carefully. When we do cryokinetics, they are doing it with us. It's not something that we give them at home. It's something that we monitor. But again, as soon as we can start that exercise, we help to push away the side effects of that lack of activity the muscle inhibition and the stiffness in the joints and the delayed healing that we know happens from these things. So the physiological effects that we get with this post-immediate care, a lot of these are going to be repeats from the immediate care. So I'm going to go through relatively quickly. We get that decreased temperature. And like we talked about, that's not an even process. We get that temperature gradient. It's going to be larger at the skin surface, and the deeper one is going to continue to cool even after the removal of the modality. So that thermal gradient creates both in the tissue as well as the modality, which is one of the reasons in the immediate care we talked about shaking the ice bag or doing something like that so that we restore some of that cold directly in contact with the skin. Tissue destruction can also happen. This is not our goal. It happens with extreme temperatures. This could happen if we used a gel pack directly to the skin, but with ours, the other mechanisms that we have that we're going to talk about, that won't be an option. So something that can happen, but hopefully not. Increased or decreased inflammation. So that can be kind of confusing, right? So we know when we do cold that we're decreasing that inflammation, right, by decreasing secondary cell death. However, it's probably not true that cryotherapy actually truly decreases the inflammation. It's going to decrease the side effects of that inflammation and the larger extent. There's also concern that there could actually increase inflammation, and all that means is that it can facilitate the inflammatory process. So again, by potentially helping to limit some of the edema formation and cell death, we could potentially get some of that pro-inflammatory response. Decreased metabolism. Again, that increased cooling, decreased needs for oxygen, that's all good for our post or for our immediate care. That's less of what we would be using it for post-immediate care. Decreased or increased pain. So ideally, we're trying to decrease pain, right? We had our flow chart and we saw that we go through both level 1 and some level 2 pain relief. We get that enkephalin release with the ice. So the research shows that cold decreases pain. However, there is cold pain. We actually get pain from the cold. And that is, again, those 4 sensations where we go from cold to burning to aching to numb. And so that cold pain can be enough to deter or kind of deter someone from using the cold. And so we want to kind of mitigate that. Education is a big part of that. Another option is what we call toe caps, which are just neoprene sleeves that you can put on the toes or the fingers. Since the toes and the fingers are going to be most susceptible to the cold and the cold pain, that helps to kind of warm those areas, unless we're trying to actually treat those areas. So, you know, if it's a toe injury, we don't want to put a toe cap on, but if it's an ankle injury, we can put a toe cap on, and then the toes stay a little bit warmer, decreases that pain. That'll be another activity that you will actually work on when you're in class. 2 other types of pain that come into play when we're talking about cryotherapy: residual pain and re-injury pain. So residual pain is the pain caused by the injury. Okay, so it's the pain hanging around because of the inflammatory response cycle, because of that increased pressure from the swelling, because of that sensitized nerve endings, because of the chemical mediators. All that is residual pain. That is what our focus will be on the post-immediate care. We're trying to get rid of some of that residual pain so that someone's more apt to want to exercise. So we pay attention to that pain. Okay, that's what we're trying to neutralize. Re-injury pain, okay, where the tissues have been re-stressed to the point of potentially re-injuring, either micro or macroscopically, that does not get affected by the numbness. So when we apply cold to facilitate exercise, if they all of a sudden experience pain when they were numb, that might be a chance that it's a re-injury pain. And so we pay attention to that, and we stop and we back off and go back a couple steps in our process to make sure that we're not re-injuring the tissue. Also, we're going to get decreased muscle spasms. You know, it's important to think about the difference between a cramp and a spasm. So the cramp is that sudden, intense, painful tetanic muscle contraction that usually lasts less than 20 seconds. The spasm is kind of more continuous due to injury or, again, kind of microscopic injury to the area. The spasm might also be what is generated post-injury to help splint the area. So tightness in the muscle, a little more gradual, potentially an unknown mechanism. Both of those can be affected by the cold. So good to know that. And we get that by decreasing the nerve conduction velocity, breaking up the pain spasm cycle, affecting the reflex mechanism. So we decrease the sensitivity of the muscle spindles, all those things we talked about in our physiological effects of cold. We also get into increased tissue stiffness, so resistance to movement. It increases the viscosity of our fluids, especially the viscosity of our joint synovial fluids. We get decreased muscle power, decreases the connective tissue elasticity. Cold will also hinder our fine motor skills, but not our gross motor skills. So it might be hard to button, your shirt when you're really cold, but it doesn't really affect you walking or moving around. So gross motor skills are usually okay. Fine motor skills get a little bit hindered. Decreased arthagenic muscle inhibition. So that is that distension or damage to the joint. So when the swelling occurs in the joint, so thinking the knee post ACL surgery, right? It inhibits the muscle surrounding the joint. So we see that quad really become inhibited and atrophied. That doesn't need pain to happen. It just needs the distension of the joint capsule. So that can get reversed with TENS and with cold. We can actually facilitate recruiting more neurons after, which would facilitate exercise. So cold helps to facilitate muscular activity above normal levels to help overcome that arthrogenic muscle inhibition. So that was when we were talking about that inhibited muscle back in our physiological response video, that we increase the number of motor neurons and motor units recruited. Decreased circulation. So research shows that there is a decrease in the circulation due to cold. Okay, we vasoconstrict the arteries leading away, or to the area, I should say. We get that decreased circulation because of the blood viscosity. There is some confusion with this. Long time ago, people were confused because the tissue turns red, right? And red usually means warmth. Or they were actually finding when they measured, especially in fingers, that after a certain amount of cold, we were actually seeing vasodilation, and it's what we called the hunting response or the rebound effect. So this is from your book. This kind of shows the hunting response, where what was predicted or thought about when they looked at this was, so this is our normal diameter of a vessel. We vasoconstrict when we apply cold. Okay, that's what we would expect. But then when cold was maintained, we saw an increase in the blood vessel dilation. This is what they thought was happening. What actually happens is down below. So we start at this size, we vasoconstrict for a while, and then eventually we get to kind of a plateau where we actually go back and get a little bit of dilation. But that dilation is not even back to the normal level. Okay, so this is not what happens. This is what happens. So we don't actually get this cold-induced vasodilation in that it increases the surface area or the diameter of the vessel larger than it's resting. It just goes from its negative furthest point to just slightly larger from that negative point, but not back to the original. So that was that vasodilation or hunting response. And again, it happened most often in fingers. The skin redness that was usually found is actually histamine release. So even if you don't have cold urticaria, where you have a full-blown allergic reaction, that skin redness happens because histamine is released when those thermoreceptors are signaled. We do get this increased rate of healing, which also made people think, well, that must mean more circulation because we need circulation for that increased rate of healing. That actually usually probably has to do with the fact that by applying the cold, we can facilitate exercise and it facilitates the healing process better because of using the cold, but not because of the cold. Sensations of the cryotherapy we already talked about, right? That first it's going to be really cold, then we're going to have that pain or kind of warming, burning sensation. We're going to have the aching and tingling, and then eventually to the numbness. So again, this warm burning area made people think that there must be some heat involved happening, some reaction in the body, and it's just not true. So what are the techniques that we can use for post immediate care cryotherapy? So we're going to really focus on the cryokinetics here, how to facilitate that exercise. We'll talk a little bit about the cryo stretch right now, which is the fact that cryo stretch combines the effects of the cold application with passive stretching. So it's sometimes called spray and stretch, where you use a vapor coolant, right? So cold spray, and that's usually a fluoromethane spray, to rapidly decrease the skin temperature and reduce the pain transmission. And then you combine that with passively stretching to relieve the local muscle spasms in order to effectively reduce the amount of pain and spasm associated with strains, trigger points, things like that. So you can use a spray, or you can actually use ice massage that we'll talk about in the next video, where we numb the area with the ice massage and then do the stretch. And sometimes we add some of that massage with the stretch for the cryo stretch there. Lymphedema pump, we're going to talk about intermittent compression, where we give intermittent compression to a body segment with either air or chilled water. We're going to talk mainly about the chilled water, that it goes into a sleeve and provides pressure. It's usually in an on-off time so that it can force lymphatic drainage, where you can set up gradients that it pushes in and then relaxes and pushes again to help decrease the edema. And then there's some other ones that are out there that more and more evidence is coming back that they don't work as well. Connective tissue stretch is actually one that we taught for a long time. It's in another textbook we have here. There are some people that really swear by it, but evidence is super mixed on it. And it was a combination of using heat and long-term passive stretching, and then putting ice with stretching. So you use the heat to kind of relax all the collagen so that it would extend, and then in that extended position you put some ice on it so that the collagen would harden up in that lengthened position. And again, anecdotally, people see really good results, but the research hasn't really backed it up. Contrast baths are a whole nother thing too. So the concept being you would go from warm to cold. So whether that was with like an ice pack or a hot pack and an ice pack, or whether you did tubs, a warm tub and a cold tub. But the idea being you were trying to create this like pumping effect, right? So the blood vessels would dilate, then they would constrict, then they would dilate, and we would help to pump out. It's just showing research-wise that you're not in either temperature long enough to get that response to happen, and that then the transition doesn't happen quick enough to the other one. So contrast baths, which your book talks about them, but they're essentially really being told just don't use them anymore. And then our last one here, we have the cryotherapy for the whole body recovery. So this is a lot of the research that goes into cold tubs and using cold tubs for recovery from activity. Again, research is pretty mixed on these, and it's either using cold tubs, so cold water immersion, or whole body. There's also like saunas that are actually cold, so you step into like a chamber that's excessively cold. Really conflicting reports on how this works and if it works. A lot of it seems to be psychological or kind of placebo effects. So I would suggest that's something that interests you, you look into it more. But as far as our purposes go, we don't necessarily see the results therapeutic wise. So again, not something that we would look at specifically because someone has an injury and it would be an option for our therapy. So again, just thinking back to our general indications and our contraindications. So again, back to that chart, but this is just kind of a different one, someone from some different examples, things we've talked about post immediate care. So we had, the treatment of the results of inflammation, painful conditions, acute swelling, muscle spasms and cramps, trigger points and headaches, burns, decreasing pain for injections, minimizing cold sore development, preventing heat exhaustion or heat stroke, right? That would be more of that whole body cryotherapy. Talked about menstrual cramp relief. It's even used to decrease the chance of hair loss when receiving chemotherapy. And again, here are some of more of specifically from your book. When we take out that acute injury or inflammation, specifically that would be the immediate care, we see all of this pain relief, preventing edema formation or helping to reduce edema formation, using in conjunction with exercises, decreasing spasticity, muscle spasms, nerve pain, all of those things, and keeping in mind all of our contraindications that we're always focused on.